I think we'll just move straight on and meet some of our radiographers working in research here at the Christie to highlight some projects that they've been working on. So the first, we have Lisa McDade and possibly Lindsay Cooper, who are going to give us a short presentation about some work that they've been doing in MR-Sim.
So we were quite in a unique position of setting up an MR-Sim service, only the second in the UK to be specifically within a radiotherapy pathway. And this was housed in the Proton Beam, the new Proton Beam Centre. There's very little evidence in the literature about which sequences to use for radiotherapy planning. So we essentially set up the service using evidence from the radiology evidence base and optimise them in accordance really with the on-site radiologists, clinical oncologists. But what we wanted to do was audit the image quality and just ensure it was appropriate for radiotherapy planning. So we have started, so I'll just scroll up to the methods. We reviewed the head and neck patients imaged in the first few months of the service opening, and there were 16. All our patients were imaged in the treatment position. You can see a graphic of treatment position there. One complication that you probably know about using MR is we can't use conventional coil configurations. So we have to make do around the patient with flexible coils, and that does create some problems from a physics point of view. So all our patients imaged in treatment position in their masks. Sequences used were a combination of T1 and T2 weighted. Different tissues in the human body are more conspicuous on different MR sequences. So consequently, you need a combination of sequences to make a protocol. Hence the need for 4 that we used. Patients were imaged axially from superior orbital margin down to sternal notch, and for our audit we used an absolute VGA. We felt that was the most reproducible tool. We used a Likert scale from 1 to 4, going from very clear to not visible, for a list of predetermined structures, and they were the structures that were the OARs and likely to be needed on the for the treatment planning. So our results: overall scan time was just under 32 minutes. The mean in-room time was 64 minutes. It's a long time. The setup takes quite a long time. If we go to table 1, that was the composite VGA scores. And we can see that just under 70% of the sequences and structures were acceptable for use in treatment planning, and they were ranked very clear or clear. As we said, different body tissues are seen on the different weightings, hence the need for the combination of a few sequences. We then broke down the structures, and we can see when we look at table 2 for structure clarity, the overall, between the 4 sequences, all structures scored at least 78% clear or very clear. So in conclusion, reviewing a newly developed MR-Sim service by using this absolute VGA has allowed us to start to implement continual quality improvement processes. We can compare the performance of individual sequences, and that's allowed us to identify some sequences that might be eliminated if we want to make way for new sequences as they're developed. This tactic it allows us to ensure that protocols are up to date, they're evidence-based, and we've got some sample images for you to see there, T1, T2 and a T1 FATSAT. Future aims: we started with head and neck, and we will move on to the other sites that are treated with proton beam therapy over time. And that's the end. Thank you.
That was great, Lisa. Thanks for that succinct description of your project. So this work has been accepted. It would have been presented at ESTRO this year, which is why it's in poster format, by Lisa and Lindsay. So we're a little bit ahead of schedule. Is David Roberts in the room?
He is indeed, and I'll keep sharing screen, and I can just flip on to David's.
So David works with us in our proton therapy department. He's not specifically a research radiographer, but he is very research keen and research active, and this is some work that he's led in the new center.
Okay, hi everyone. So this is about the assessment of setup accuracy using VAC-BAG systems. It was primarily done in a proton beam therapy department, but the results are relative to standard radiotherapy. A VAC-BAG is a VAC-BAG. So to answer this question, we looked at three main areas. They were timings, so that was setup times, image review times, and total treatment times. We also looked at cone beam CT image displacements to see how accurate the setups were within the VAC-BAG. And then we also looked at the image agreements between 2D and 3D imaging. We've got quite a unique, or we had quite a unique imaging collection process when all this data was collected within the proton therapy department, which you can sort of see there. So we've got three images before we start treating the patient. I'll just go through that now to give you a bit more background to the results. So we set up the patient as normal, and then we proceed to image one. Image one is an initial 2D image just to check for gross error, just to make sure the patient is in the right position. We make no moves off this image. If we're happy with that image, we'd then proceed to image two, which was a cone beam image. This is our gold standard image. We'd apply the moves off this. We have quite small tolerances on this image of 0.1 centimetre and 0.2 degrees. So moves will almost always be implemented, as in this cohort of patients that we had here, 100% of the images had at least one measurement out of TOL. So every time we applied the moves, and then once we applied the moves, because of the manufacturer requirements of the bed that we're using, we have to then take another verification image to make sure that the bed is moved to the right position. So we've got a three-step imaging process there. So moving on to, so a bit of the data collection. So what sort of data were we playing with? So we also did the first 10 patients within the department that came through the department, and that took 6 months. It was quite a slow ramp up. So the data was collected between December 2018 and July 2019. And from that, we had 4 GA patients who were supine, 6 non-GA patients who were prone. All the patients were treated in the pelvic and lumbar region. And then we had quite a lot of images to play with from that, where there were 299 initial 2D images, 181 cone beam images, and 180 verification images. Okay, moving on to results. Oops. So starting off with timing results. So we broke down these into 3 areas as well. So we start with setup time. So this was the time taken from the patient entering the room to the initial image. You can see there that there is, so we've reduced the setup time by half over these first 10 patients. There was still a lot of fluctuation within each patient though. For example, the most recent patient, patient 10 there, had a setup time range of between 4 minutes and 34 minutes. So there's a lot of fluctuation. So review time, cone beam review times, interestingly, that has increased over these 10 patients. We'll discuss the reasons for that a bit more later. And then the total treatment times has fallen slightly from 50 minutes to 40 minutes. Now, these are just the VAC-BAG patients, so they do tend to take a little bit longer than our other patients, but we'll discuss a bit more about the reason why they were taking that amount of time a little bit later. Okay, moving on to the displacements results. So this is just looking at the 3D image, just the cone beam CT data. So we used our action tolerances. So within the department as well, we have action tolerances of 1 centimetre and 2 degrees. So they're the measurements that, or the tolerances that a radiographer can apply before they need more senior involvement. So I've used those tolerances to display the results. And as you can see, that 100% of the translational measurements were within those tolerances, which is good. The rotational measurements were a slightly different story, more variable, didn't reach 100% for any of them. If the measurements are out of TOL, like they were sometimes here, then we would assess on an individual basis, get more senior people involved. But the maximum that we can correct for on the 6 degree of freedom bed is 3 degrees, and overall 99.8% of rotational measurements were within that. So that's still pretty good. Okay, image agreements. So we wanted to see how viable it was to move from 3D to just doing 2D. So we weren't doing 3D every single day. So we looked at how agreeable 2D was with 3D. So for the initial 2D to the subsequent cone beam, we used a Bland-Altman plot, which is a method for analysing the agreement between 2 different data sets. This showed that 95% of the time, the gross error check, that initial 2D, would be within about 3 millimeters of the cone beam. That's for translational measurements. The rotational results were more varied and showed that in the pitch, the 2D image would underestimate the 3D image slightly and overestimate the roll slightly, almost by to a degree at some points. This is sort of creeping into the area of not being that acceptable. So we've got something in place now where we assess, when we're doing our systematic review, we also assess the agreement between 2D and 3D to see whether they can proceed on the standard 2D imaging protocol, or they should stay on daily cone beam. We also looked at the cone beam versus the final 2D and how agreeable they were. So once you've applied your moves from the cone beam, you would expect in a perfect world when you take your 2D image for the measurements to be 0. That's not always the case. We can see that the overall agreement there for translations was 89% and 94% for rotations. And interestingly, it was much more compliant with the GA patients rather than non-GA, which would imply that it was more down to very small patient movements rather than the bed not going to the right position, which is reassuring. So, a bit of discussion, timings are improving. Yeah, so to go back to why the timings were taken that amount of time. It was a new service. We had a lot of sort of daily issues, a lot of uncertainty about how what we were seeing on the images would translate into the dosimetric effect. So we were getting the physics and clinician involved quite a bit at the beginning. There was also a brand new service, so there's a lot of training going on that obviously delays things. And there's quite a bit of patient resetup as well. So to achieve that 100% translationals within tolerance, we had, over the whole course of those patients and all the fractions, we had 38 resetups to get to that. Displacements, we were happy with the displacements, so they were in acceptable limits. And the image agreements, they're fine for translations, but the rotation's a bit more variable. So like I said before, at the systematic review to assess that. So in conclusion, vac bags, they are suitable, but we need to have the systematic review to look at the 2D and 3D agreements. We need a 60 degree of freedom of couch to make sure that all the rotations and everything are applied to make sure that we can accurately position the patient for treatment. And that's it. Thank you very much.
Great, that's great work, Dave. So Dave's work this is his poster that was due to be presented at Astro this year as well. So I'm glad he's had the opportunity to present it here. The next up is John Rogers, who's our RadNet research radiographer, who's been absolutely instrumental in helping us set up the MR-Linac, and he's going to talk about a little bit of work that he's led.
It's the PowerPoint.
How do we get it started? Oh yeah. Hi, as Cynthia said, my name's John. I'm the RadNet radiographer. So yeah, the MR-Linac, it's a new device, it's a research machine, and it's essential that those operating provide evidence of its effectiveness. And there's been a focus on radiographers leading research on the machine. And these studies need to be sophisticated enough to provide relevant evidence for our practice and the care of patients. And like most things on the MR-Linac, it's proven to be a pretty steep learning curve. So MR-guided radiotherapy, it's introduced MR to CT image registration into the workflow. Requires radiographers to be proficient in both interpreting MR images and registering them to a reference image accurately and efficiently. Before our first prostate patient last May, the 3 radiographers who were working on the MR-Linac wanted some assurance that we were with a novel imaging modality, we were all doing the same thing. So we ran a small exercise to confirm that our registration agreement was acceptable, and the results are really reassuring and compared well with work on cone beam registration in the department. So our next treatment area is cervix.
We can't see your slides. Well, I can't see them anyway. Sorry.
All right.
Oh,
I think it's still on the PDF page for Lisa.
oh, is it you share?
Yeah. Is that on? Yeah. No. How about now? Any better?
Yeah, thank you.
Sorry.
Thanks, Rosie. Cheers for that. Nice heads up. Yeah, so our new area is treatment area will be the cervix. It's potentially a more challenging area for accurate target registration, and the rectal and bladder changes can lead to. It would be good if this worked now. They can lead to certainly changes in the target positioning and quite a challenging situation day to day. So we did feel it was important to quantify image registration agreement, and we wanted to establish that prior to implementing cervix as a new clinical site for MR-guided radiotherapy, that MR registration was comparable to established cone beam CT processes. We had a secondary aim as well, and that was to identify elements of the registration process where further training would be of benefit for the radiographers. So how we went about it, well, we were fortunate enough to have on treatment and MR images from 10 patients in a previous study, 5 therapy radiographers with some experience at least of MR and Monaco participated. They matched cone beam and MRs taken on the same day with reference CT planning scans, and also matched MR to MR using the earliest MR that we had as the reference image. As far as the results go, we looked at inter-observer variation between the MR, CT and cone beam CT registration, and the results are very similar really. There was very little difference, and kind of sort of led us to the conclusion that registering an MR is at least no worse than using cone beam. And to evaluate consistency of agreement, well, yeah, we used Bland-Altman. We used modified Bland-Altman plots, and this process, as you've seen from David's little talk, establishes limits of agreement, and these can be compared to a threshold. And to assess clinical significance, we opted for a threshold set of 5 millimeters, which is kind of based on our departmental ITV to PTV expansion margin for Embrace 2 patients. It's quite a busy slide this, but basically limits of agreement were consistent for all 3 registration strategies in the right, left, and the SUPINF in the SUPINF directions, whilst MR to MR registration demonstrated improved limits of agreement between observers compared to cone beam and MR to CT in the AMP post. Cone beam CT and MR CT limits of agreement exceeded the predefined clinical acceptable threshold we set at 5 millimeters in that AMP post direction. So the obvious benefit that MR has, which is, we've seen it while we're treating, which is far superior soft tissue contrast, appears not to readily translate to improvements in inter-observer agreement when we're registering images. So trying to think why that might be. Well, the lack of experience when interpreting and aligning MR images to CT may account for some of the inconsistency. Another possibility is that broadly similar appearance of cone beam and CT that we're all used to guides observer registration and improves agreement. So as radiographers, the results were disappointing. To say MR-guided radiotherapy is no worse than cone beam CT didn't strike us as particularly satisfactory. Neither did this AMP post level of agreement exceeding the threshold of 5 millimeters. We looked at potential weaknesses of the study and identified that maybe how we'd instructed observers to match the images as a possible flaw, because whilst they'd all undergone an MR anatomy session, for the cervix with a clinician, they'd only been instructed to match the cervix. Therefore, our next step was to introduce the registration protocol manual and validate it, or at least attempt to validate it, in order to improve radiographer agreement during image registration for cervix MR-guided radiotherapy. So we repeated the registration following the creation of a registration guide. This is an example of it. The guide was developed collaboratively between therapeutic and diagnostic MR radiographers in consultation with clinicians to identify the most relevant anatomical regions for registration in an attempt to standardize the process. The manual was used as guidance in the repeat registrations, and the results, well, there were improvements in all planes, but most notably in the AMP-post plane, which previously had the largest variation. So that was really rewarding, to be honest. The study confirmed that the application of this guidance manual resulted in significant improvements in inter-observer agreements, at least with the participants included within it. But to truly validate the results, it needs to be replicated with radiographers without experience of MR image registration of the cervix, and we're working towards that at the present. However, this work is already becoming outdated as we're introducing MR to MR registration on the MR-Linac, and I think it emphasizes that research is highly dynamic within the radiotherapy environment at present, and particularly with the advent of MR-Linac and the new possibilities that arise from it. So it's important for us as researchers involved with that to be as smart and innovative as possible to stay ahead of the curve. That's it, actually. All done. All done.
Perfect. That's really great work, John. And thanks for the very nice summary. So I think our last speaker of this session is Rosie Hales. She's a research radiographer who works on the MR-Linac with us at the Christie, and she's going to present a little bit of her recent work. Rosie, you ready to share your screen?
Yes. Do I need John to stop sharing his first? Sorry.
I think you can just say share screen, no?
Oh yeah, sorry, yeah, okay. Okay, can you see that my slides okay?
Yep.
Okay, so yeah, as Cynthia said, I'm Rosie Hales, and I'm just going to talk about treatments on the MR-Linac and how radiographer-led research is helping to increase efficiency in our treatment delivery. So for those of you who might not be aware, MR-Linacs are hybrid systems which combine an MR scanner with a linear accelerator, and the Elector Unity is the MR-Linac that we have installed here at the Christie. So each fraction delivered on the Unity is an adapted fraction, and this is supported, as others have mentioned, by superior soft tissue contrast of MR over cone beam and standard CT. This brings with it the necessity to establish new ways of working. The Unity is capable of adapting daily fractions online while the patient's on the bed, and this is following two different work streams. The first adapts for daily positional changes, which is akin to a virtual couch shift, where the plan is moved to fit the patient, and this is known as adapt position, or ATP. The second work stream allows for adaptation for daily variations in anatomy, and in this work stream, recontouring of targets and organs at risk and online replanning is required, and this is known as adapt to shape. In both work streams, the responsibilities of the frontline staff delivering the treatments can differ slightly. So at the Christie, we began treating in May last year, and this was following adapt position for prostate patients receiving 20 fractions. These treatments are by nature resource intensive due to the various steps involved. This diagram shows the various steps involved from delivering adapt position fraction from top to bottom. And here you can see the various disciplines that step in at different points at our institution. So for an ATP fraction, for our first two patients that we had at the Christie, we had the full complement of 5 staff present for treatment. This is 2 therapeutic radiographers, 2 physicists, and 1 clinician. So as you can see, each plays a role at different points, and the average in-room time for these treatments was 36.5 minutes. The responsibilities of the therapeutic reds involved in the delivery of these fractions include safe setup, image acquisition, image registration and treatment delivery. And these core responsibilities are the same as for standard CBCT guided treatment, albeit with a bit of a step change in the technology used. So this led us to believe that with the acquisition of some extra skills, these adaptive radiotherapy fractions lend themselves to being radiographer-led, and this would offer a more sustainable solution for integration into a radiotherapy department. So in terms of methods, the first step was to identify the skills required by the therapeutic radiographers to lead these treatments on the MR-Linac. And these skills here are those required for an adaptive position fraction. The green skills represent those that are standard for cone-beam CT guided treatment, so setup and delivery. The amber skills, CT MR registration, treatment plan preparation, evaluation and check-in, are within the scope of practice of a therapeutic radiographer, but these represent additional skills for our radiographers who do not rotate into treatment planning as standard. The red skills are outside the scope of practice currently of a UK therapeutic radiographer, such as MR image interpretation acquisition. So once these skills are identified, these were acquired through various different methods, such as attending external courses, internal courses, tutorials, discussions, self-directed learning, and teaching of colleagues. As others have mentioned, interdisciplinary discussions have been key to this research. And these were required with other members of the treatment team regarding how responsibilities should change in order for these treatments to become radiographer-led. It's worth noting that small steps may be needed according to local resource and policies. So our first step at the Christie was to introduce a clinician light way of working where the clinician is on standby and only contacted if needed, and this is to reduce the resources required for treatment. Following on from these discussions, clear action thresholds needed to be identified and agreed for contacting the clinician on call and for taking certain steps, and these needed to be well documented, producing a clear frame of working that all stakeholders could follow. So this was our initial workflow for the first 2 patients treated at the Christie, and following this method, a clinician light frame of working was developed for prostate adaptive position treatment. So this was moving the clinician to an on-call position. This clinician light framework is shown here in B. So the same steps were involved in the treatment, but the responsibilities of the radiographers and physicists have expanded, and the doctor is moved to an on-call position. So 10 patients were treated following this workflow, and the timings of certain steps were recorded and compared to the first 2 patients. Following the framework, a clinician was required to attend for 1.5% of fractions for reviewing dose criteria online. In terms of actual time taken, a reduction in time can be seen for certain steps in the workflow where the responsibilities have changed, and for overall in-room time as well. And this has continued to decrease through treatment delivery. A degree of this reduction can obviously be attributed to everyone involved being more familiar now with the software and the treatment process, but hopefully it demonstrates that we've implemented a more streamlined treatment workflow and a better use of resources. In the near future, the appropriately trained MRL radiographers will be taking over the role of the first physicist and undertaking simple online treatment planning for these adaptive position fractions, which will further improve the use of resources and reduce the staff required for a fraction to be delivered. And this new workflow is shown in C, with 2 radiographers and 1 physicist present for treatment. In the future, we'll also be introducing the adaptive shape workflow, which, as I described earlier, involves an extra recontouring step, and online planning is more complex. In order for this also to become clinician-light in the future, and for radiographers to expand their responsibilities in order to pave the way for more radiographer-led treatment, after initial experience of patients, there must again be significant interdisciplinary discussions, feeding into identifying and agreeing new action thresholds that are appropriate for this treatment technique, as well as significant time spent on gaining additional competencies such as online contouring and complex planning. So in conclusion, this clinician-light adaptive position workflow developed here is one step towards radiographer-led MR-guided adaptive radiotherapy delivery, which we've shown to be more efficient and has allowed role expansion for those involved. and it's more akin to standard CBCT guided radiotherapy delivery. Implementation of this required agreed and clear thresholds, and for implementation of any other sites or for more advanced treatments, further interdisciplinary discussions will be required. Just a few acknowledgements to everyone involved. That's it. Thank you.
That's great, Rosie. Thanks very much. And thanks to all 4 of our speakers. So we have some time. And again, I'd like to encourage people to give me some questions through chat, or if you're impatient, just shout something out. If all 4 of the speakers can make themselves available to answer some questions. Questions can be either specific to the project or more about how the research radiographers balance their time or in their experiences. Anybody have the first question? If not, I'll go. So I think, Dave, I'll start with you, because you're not currently working in a research role. So how are you finding the desire to get some research done and the ability to balance it with your clinical job?
Well, when I was doing this project, it was quite easy because it was when the service was ramping up, so we didn't have that many patients, so we did have a lot of spare time to do these sort of projects. I'd say now, if I to attempt to do something like this now, I'd probably find it very, very difficult. It did take a lot of time. Okay,
good. Professor Chowdhury says, how easy or hard is it to research your own ideas? Anybody want to tackle that question? I'll pick on people if you don't volunteer. Okay, Lisa, I can see you thinking. Lisa?
I'm putting a sentence together. I'm engaging brain before.
I think it's an easy environment to discuss ideas with lots of other disciplines. Obviously, you've got to bear in mind, for us on the MR-Linac, our first concern is research that involves the MR-Linac and patients as well. So it depends on what area you're in, but I think it's a good environment to be able to discuss with a lot of the other disciplines and get ideas from them, and to collaborate with other people as well.
I'm going to take that as a general consensus because I don't see anybody grimacing too much. John, Professor Van Herk has a question for you. He says, interesting that setup and review takes quite so long. Oh, maybe it's for David, sorry. Interesting that setup and review takes quite so long on protons. Have you compared to similar pediatric setup on photon machines, and why is it different?
No, I haven't yet. I think the reason why these setups and imaging was so long was because it was a new service, and there was lots of uncertainties with everyone there about the dosimetric impact of what we were seeing on the cone beams. So we had to get a lot of help to make those decisions about whether to go ahead for treatment or reset up. Looking at the service now, I can only say from what I've seen and working within the service now, we're a lot quicker, we're a lot slicker. A general VAC bag patient will probably take no more than 30 minutes for setup and treatment. And CNS patients, patients in a mask, 20 minutes. And that's more standard to what we're working with now.
Great. And John, Professor Van Herk does have a question for you. He said, would the same guidance document also been helpful in CT to CBCT guidance?
Yeah, I mean, we're wondering whether it could be translated over to cone beam, really. Obviously, one of the issues about this document would be that, it's looking at a particular organ, and when we're reviewing, we're not online, we're considering organs at risk and all PCVs, but certainly it's something we're considering for things upper abdominal work, which is quite difficult and challenging in cone beam, and also with the advent of prostate saver as well. That's another thing that we're certainly talking about, whether we can have some specific guidance, consensus agreement, which shouldn't be done, in isolation. It'll involve other elements of guidance and, discussion with more experienced radiographers, but at least give people a good idea of what's expected, what thresholds, and what kind of imaging strategy you need to do. So, yeah.
Great. Rosie, there's a question for you. It says, you mentioned it's good to work with the MDT teams on the projects. Do you find many of you need to get further support, such as from statistical analysis? And if yes, where do you get the support from?
Yeah, so there are statisticians that we can talk to at the Christie, but we also have regular meetings with the academic research team who offer advice as we need it for projects, really. So it's quite a nice collaborative atmosphere. And there's also, if you know, meetings where you listen on other people's projects, you often find the answers for your own as well. So that's my experience. I haven't had to use official statistician support yet, but I'm sure I will soon.
John and David, you both have for your projects, I believe, yes?
Yes.
Yeah, absolutely.
And one final question from Prof. Chowdhury. This is to everyone. The project work going on in the Christie is what we've been discussing, but how will we find out what's going on at other centres?
Well, we discuss things, and you know, we try and we've built links with the MR-Linac in Royal Marsden, for example, and you know that kind of obviously have the RadNet meetings as well, which is really helpful in that respect, and that you get to meet the other RadNet radiographers. So there's a networking opportunities and collaboration through that, yeah, I mean that's one aspect. Anyone else?
What about the big thing that we're just missing out on? You all were going to present at Estro.
I was going to say Astro, yeah. Networking and getting posters out to, and then you see what the other groups are doing, or even the society conference, and you see what other groups are doing, and then you make you see something that interests you, and you make contact with them that way.
Mike Vellick is plugging RTT conferences, so I think that's specifically the RTI3 conference that they hold every year in Toronto. It's a radiotherapist specific meeting, which I don't think any of our team outside of myself have yet to attend, but it's good. Again, from Prof. Chowdhury, do any of you think social media such as Twitter is useful for communicating?
It's nice it's nice to see names that you know, and I think a lot of the not radiotherapy related, but a lot of the COVID related research, for example, some of that's been really interesting on Twitter, and just to see what the other groups are doing.
What about things like the MedRad Journal Club? That's a Twitter journal club.
Yes, we joined in the MedRad Journal Club. That's every month. That was an experience. That was interesting, and it's good to see different viewpoints from around the world of different practices in different countries, and how similar it is.
Great. Well, I'll let you guys off the hook now. Thank you very much for presenting and for all your hard work as always.